Hello and welcome to this episode of our podcast series called Conversations in Health and Care Improvement. I'm Amar, Chief Quality Officer at East London Foundation Trust and National Clinical Director for Improvement. And this episode is focused on the topic of productivity. I'm really delighted to be joined by two fantastic speakers and thinkers and practitioners who are going to hopefully bring this word productivity to life to us and help us make sense of it. So thank you, Thea Stein and Louisa Wickham, for joining us on today's episode. I wonder whether we could first invite Thea to say hello to our listeners. Thea, you're the Chief Executive of the Nuffield Trust, which is an independent health think tank. And prior to that, you were Chief Executive of a community health trust in England, weren't you? I wonder if you could just say a little bit about yourself, your background, and something about what productivity means to you.
Sure, thank you. As you say, I've been the Chief Executive of the Nuffield Health and Social Care think tank for a year. It's not the organisation that runs the private hospitals, and it's not the organisation that runs the gyms, just so that everybody knows. So I do get emails about that every fortnight or so, but I don't do any of those. But we are a politically independent think tank that works to help make policy better across the UK is our charitable purpose. For 9 years before that, I ran a medium-sized, I suppose you'd say, community trust and mental health services trust. I've done all sorts of things in my career. When I had a proper job at the beginning of my career, I was a clinical psychologist and family therapist. So I have spent time clinically, but it's a very, very long time ago now. Productivity. When I joined the Nuffield Trust, I don't think I imagined I would end up both writing and speaking a lot about productivity, but it felt to me really important that, as it was such a live conversation in the NHS and in politics, that I understood it well enough to walk into a room, talk knowledgeably and engage with people about the subject outside of maybe my specific experience. So I started reading widely and talking to people. And from that, I became extremely interested in productivity, but I became extremely interested in why we were having what I called very unproductive conversations about productivity. And that sort of was part of the path I went down as I started to learn and explore, was why are so many things so stuck? So I'll leave it there, Amar, at this point.
Fantastic. And it was those writings there that nudged me to invite you on to this podcast, because I think there's a lot we could learn from how you've thought about this word productivity and what it might mean to us. Louisa, welcome. Louisa, you're a consultant ophthalmic surgeon, medical director at Moorfields Eye Hospital, which has a global reputation in its field, and also the national clinical director for eye care in England. So welcome. Thanks so much for joining us.
Thank you. Yes, so I come to this really from a very clinical perspective. So I am still an active clinician at Moorfields Eye Hospital. I'm predominantly a retinal surgeon, but have had an interest in how clinicians can get involved in improving the quality of healthcare for patients for some time, which is what led me to become the chief surgeon around the time of COVID and preceding COVID, and then latterly medical director of Moorfields Eye Hospital. And I now have a national role, as you said, as the national clinical director, where I try and put some of the things I learn in practice clinically into a more national agenda. So for me, productivity, I think, is a very interesting word, isn't it? Because I think if you look at it in sort of a definition perspective, people are often thinking about doing more for a given set of resources. But I think in healthcare, I think we need to nuance that. It's not just about doing more, it's about doing more of the right thing and doing more things of high quality. Because you can do more of something, but if you're doing a lot of things that aren't high quality and are not the right thing, you're actually not improving productivity in terms of how we deliver healthcare. So I think it's very important that when we're talking about productivity, we really appreciate it's about quality and quantity and not just about quantity. So that's where I come from it. And I think that then brings in a whole interesting arena of how we achieve that in order to make sure we're doing the right thing at the right time the first time.
Absolutely. And I'll come back to you in a moment, Louisa, just to see if you can help us learn from some examples that you might have seen in practice about where people have been able to take this fairly abstract concept of productivity that may not potentially really resonate with the way in which we think about receiving care or delivering care, and then translate that into something that's really meaningful. But I wanted to take a step back first, Thea, and get your help with this, because we chose the topic of productivity for an episode on this podcast because it's had so much interest in England and the NHS over this year. But obviously this podcast is reaching people across the world in many different health economies. And so I wonder whether you might just help our listeners and viewers think a little bit about, why do we think productivity has caught the attention of people at this point? And what are we realizing might be underneath the word of productivity as we started to explore it a little bit?
Well, I think Louisa put it very well, actually, which is that we all want to know that what we're getting out for what we're putting in is the right sort of product, and is the right quality, and is the right volume. We use the language of actually quite classical and, I would say, old-fashioned economics in productivity conversations around the health service, which make it sound far more like we're only interested in the numbers of things we're getting out for the amount we're putting in, which is, of course, a classical economic definition. But actually, even in economics, I'm not an economist. I've only read enough so that I can talk as though I know a little bit about what I'm talking about. But I am really interested in behavioural economics, because behavioural economics is based on the idea that people aren't rational. Lo and behold, we all know that. People aren't rational. People are emotional. People are complex. People are multi-layered. And in the health service, which is a very, very complicated system, both in England and, of course, globally, understanding concepts of what seems simple, what you get out for what you put in, is actually multi-layered and very, very complicated. And, of course, it isn't about, I do something and there are 20 of an output. I'm making buns, I make 20 buns, and you, Amar, make buns and you make 10 buns. I'm not actually more productive if 10 of my buns are really low quality. And if 10 of my buns are bought by people who come back in and say, I found your hair in it. So actually the 10 buns, which are high quality, are much, much more useful in really thinking about productivity. And why are we all thinking about it globally? Because we will never have enough money for all the healthcare we want to consume as we both get richer as countries and as we invent more and more ways of being able to cure things, intervene in situations, etc., etc. So it's reasonable for us to be concerned really with the central question, how can we get the most out of what we put in? But the language, and we can come back to this, the language we use is language that alienates most people within clinical services. It's just not language that people relate to.
Definitely been my experience too, that the word productivity brings with it connotations that people perceive to be about, we're not doing enough.
Yes, it's a connotation of if your service isn't productive enough, or your service isn't doing as much as the service from the hospital, the community service down the road. It includes an assumption of laziness. We could say what we like. It assumes an assumption of laziness because it isn't framed with a question of curiosity, isn't framed, and we'll come to this, you know that what I've written about quite a lot of psychological safety, which I think is at the root of the discussions. I'll only really have the conversation with you if I really trust you and I'm really comfortable with you. So if you say to me, oh, Thea, I thought that you were going to have done that paper by the end of Friday. It's not like you've not done it. I may have a really good conversation with you about my genuine lack of productivity today because I trust you, because I can talk about it. If I don't, we're going nowhere.
And I think for me as well, Thea, the other aspect of that is that we work in teams. We're not individuals. And actually, as a team, our productivity is a sum of all the parts of everybody who's involved. And again, when we're having those conversations, talking to you, in your bun analogy, if I'm not making enough dough for you to put the buns in, we still can't get good productivity. So I think exactly as you say, the conversations we have, particularly to a workforce who feel that they are working very hard in what they will often feel are quite difficult circumstances, layering that on top, and also not being explicit about the fact that it's a team effort, I think also, as you say, alienates a lot of people from the discussion before you even start.
And yet, in the way the Institute of Medicine defines quality, efficiency is one of the 6 domains of quality that it calls out. So making the most of the resources we have is an important component, isn't it, around quality? So how do you think we can shift people's reaction and thinking away from just numbers and increasing the numbers to actually doing the most with what we have, which I think perhaps people might resonate with more because it brings into it concepts around what adds value and what might add less value and what really matters to the people who are receiving care. Any thoughts, Louisa, as you've been translating this into the clinical environment?
I think it's a really challenging one because all of us in the healthcare will come at this from slightly different perspectives and slightly different priorities in terms of what we consider quality. So, for example, the traditional approach of seeing patients is a very face-to-face. You come in, you see me as a doctor, I have an interaction with you and you go. Now, in ophthalmology, for example, where we're the highest volume specialty in the country, that traditional form of interaction, which patients really value, if we stuck to that form of interaction, we wouldn't have the resource and the workforce to see enough patients in order to keep them safe and reduce the risk of preventable and irreversible sight loss. So we have moved now much more to saying, right, okay, well, what are the value add bits that we do and how can we streamline that interaction such that we make the best of patient time, we make the best of clinician time. So at Moorfields and across the country now, we use the concept of a diagnostic lane, for example. So patients will attend a diagnostic hub, they'll undergo a series of investigations that are run by technicians. There is no doctor involved. That data is then reviewed by a clinician, and if there is anything that requires treatment and management, they're invited for a face-to-face appointment. And this works extremely well for conditions like glaucoma, for example. Now, that provides a very high quality service for the community and for the population as a whole. And so from that perspective, it's very high quality, it's very productive, it's very efficient. Where we need to be careful is that we take patients on that journey along with us because they may well see that as a loss of face-to-face interaction without understanding that that face-to-face interaction is now being reserved for the time that you really do need it. And the non-face-to-face interaction is to ensure that you remain safe, that you don't lose vision, that you're not at risk. And so it's making sure that when we do this transformational work, that we improve efficiency and productivity in this way, but that we also are very clear with our patients and our clinicians what's going away and what's being added.
That's a great example to bring, Louise. And I wonder, as you've been doing that work, what have been your sort of guiding metrics? What are the things that you've really paid attention to that have come directly from the people that you're trying to design this service for, that you're paying attention to make sure that you're addressing the things that they care about most? What have been those? Because I imagine they're not just about one element of quality. They're not just about access, and they're not just about resources. It's probably a combination of a few things, isn't it?
Absolutely right. I mean, to some extent, we were given permission to do this by the public during COVID because, of course, people couldn't come in for face-to-face interactions. And so this was a way of keeping patients safe. And then as COVID receded, we were able to build on that work. So the first thing is that we were given permission in the first instance to try something new. I think the other thing for me is you've got to make sure that whatever you're doing is safe. That's the first thing. So we have lots of fail-safing here, lots of ways to ensure that what we're doing is not losing patients. And then you need to ensure that you provide a service which is high quality. So, for example, if you took a traditional appointment pre-COVID where a patient would come in, they would have a number of investigations. They would usually yo-yo through a clinic. So they would come in, see a nurse, then they would see a doctor. The doctor would go, oh, actually, you need a whole load of investigations. You'd go out, you'd have some of them, you'd come back, and then they go, oh, you need a few more. Then you'd go out and find that actually it was past 5 o'clock and everyone gone home. So you now have to come back to, the next week for a test. Whereas what you're doing now is saying, actually, we really value patient time. What we're going to do is we're going to do a diagnostic lane. Now, that takes your appointment time somewhere in the region of 2 hours down to 47 minutes. And that has been the sort of average time difference change. So what we're also trying to show here is that it's safe, it's high quality, and we're valuing, hopefully, the things that patients value most, which is something that's local to their home, because you can put the diagnostic hubs more locally, something that values their time, and something that means that they don't have unnecessary repeated appointments to get the one opinion that they could have gone in one appointment. So for me, it's you've got to show that it's high quality, you've got to show it's safe, you've got to make sure you're not missing things, and you've got to show where the value add comes, particularly from the patient perspective. Obviously, from an economical perspective, we want to also show that this is more effective and efficient use of resources. Absolutely. But for me, it's critical that the patient understands that they're safe and that they're getting something that's high quality.
Fantastic. Thea, what are your reflections on hearing that story from Louisa about a way of getting underneath this word of productivity and really redesigning around what people want and need?
I think I'd go back a couple of steps, actually, in what Louisa was saying, which I thought was really important, because she picks up on something I was saying and then led Louisa to talk about the importance of the team. And I think that's really critical, and again is one of the complexities about some of the measures we use around productivity, because we don't dig into and understand the interactions often within a team, and which are really complicated. There's something that I quote quite a lot in the work that I've done looking into it, which is a huge piece of work Google did called Project Aristotle, where they looked at productivity of their teams of engineers across the globe. And this was not an organisation looking to do anything except find out who were the most productive teams of engineers in order to understand how they would maximise profit. What they found was, in a massive piece of work, and Google collect more data on their employees than any organisation in the world, they even know who you sit next to at lunch, is they found out, at least they did at the point they were doing Project Aristotle, was they found out that the teams that were the most effective were not the teams that had the best qualified engineer with the best qualified data analyst with the most outstanding manager, although managers were very, very important in this. It was teams that got on really well with each other. And Louisa is obviously nodding, because in the health service we know, and I'm sure you do as well, Amar, liking people is seriously underestimated. Respecting people, the structure of the sharing values, being able to understand and openly talk to each other, all of these things actually came out of this massive survey, and it's written up in many places, to demonstrate what made the most productive teams. And I think it's really interesting. The health service find it quite hard to often really accept and embrace the importance of what is sometimes seen as quite soft features, rather than what they want to see all the time, which is much more sort of hard facts and figures, which is what they think is going to be the most important thing on something like productivity. So it made me think of Project Aristotle. The example you used, which I thought was a really great example of something that is more productive and how it's been situated with the public and presumably with clinicians as well, so they feel very comfortable with it. But it made me think of examples where things can go wrong, where it feels instinctively it will be good, but we don't actually trial it properly. And we see that in the way we have sometimes taskified flows in many healthcare settings. And I look back on my own career and think of times when I've instinctively thought, well, that'd be a jolly good idea It's a really good idea. The healthcare assistant does that, or the physiotherapy assistant will do that, and we can recruit them, and we can't recruit the specialist, so we'll do that. So you're taskifying a workflow. And actually, some evaluations that are increasingly coming through show that's not true, and that actually it becomes less productive and less effective. And I think we find instinctively we don't want to know that research, actually, but it seems to be increasingly true.
And I think that's absolutely right. And I think it's really important, as you say, that you are taking a team with you on a journey. So, for example, with the hub work, for example, we started off with initially just doing patients that were follow-up patients that we felt were already stable, that we thought and identified, that we said, okay, actually, we think this is something that we're going to try. And then as people became more confident in it, we kind of extended it out a bit more, and then we included new patients, and then we included patients that actually had only just become stable. So you need to have that confidence to listen to your team and go, well, where are you comfortable? Where are you comfortable taking this to? Whilst at the same time, I think it's important always with transformation, you have to be that slightly critical friend that encourages. Someone told me this great analogy once about riding a bike, that you learn most about riding a bike when you're in that zone of slightly discomfort, but not too uncomfortable, in that sort of part of the J curve where you can push yourself a bit, but you're not out of your depth. And I think it's important that with the transformation that we do push some of the, as you were kind of alluding to, that accepted thinking that people think, I know what's right. I know that the right thing to do is to always see patients face to face in a clinic, because that's what I know and that's how I know it. And I think for us, the other big deviation in this process is saying, actually, we need to understand that so for example, we put a lot of time and energy into ensuring that the technical workforce that run the diagnostic lanes are able to understand how the interaction with the patient is, because patients are anxious. They want to know that you're not going to lose their data, or they're definitely going to have someone look at it and you're going to pick it up. And they want to ask questions. And so how do you get a non-clinical workforce to provide reassurance to the patients that actually, yes, they know what they're doing, they know how to take them through the right test, but no, they're not going to proffer sort of slight clinical advice, which could cause more anxiety, but actually reassure patients. And so that's a skill. It's a really important skill. And so it's taking that and understanding that in this diagnostic pathway that actually each group of people have a very important part to play, and that you're valuing that and ensuring that you spend a lot of time encouraging your technical staff and educating them and improving that. So I think it's really key. One of the other places where I think we really tried to put in teamwork was also to understand that actually it's also your volunteers and the industry sector that can help. So at Moorfields, just as we were coming out of the pandemic, we ran something called a cataract drive, which was very similar, I suppose, to some of the cataract drives you might read of in some developing countries, where you literally go to a place and offer a lot of the same type of surgery in one place. So what this allows you to do, it's a little bit, and I hate to use the word, a bit like production line medicine. So you're going to do one type of procedure, you're going to do it repetitively, and you're going to organise your whole organisation in a way that allows you to safely do a reproducible procedure many times over, and that you gain the efficiencies from everybody being aligned to that one type of procedure. So with Cataract Drive, what we did was encourage the whole workforce for a week to take all the theatres and say, we're going to do one thing for 1 week, and we're all going to be aligned with this one process. And it was a real great, I think, an example of real teamwork, where everybody, despite the myriad of things that were difficult to achieve at that time with testing and social distancing and all that stuff, was that we all could work together, and we all came together with a regular huddle twice a week. We worked with the St John's ambulance crew to provide the voluntary and hand-holding and navigational support. We worked with our industry partners to ensure that we had all the right lenses. We worked with the pharmacy department to pre-pack all the drops, and bringing everyone together and everyone really being clear about what that initiative was about improved our productivity 120% for that 1 week, where we did over 700 cataracts. And so I think it's about having a momentum and a joint vision that really managed to enable us as a team to improve our productivity. And I think for me, that's a really good example about how productivity is the sum of all the parts that work together when you can get them to align.
And at the end of the day, it's clear listening to you that people were able to bring people with them. People wanted to do it. People understood what they were doing and why they were doing it. And also all the issues had been listened to. And I think that sometimes when I talk about psychological safety, I think that I have been asked, sort of like, do you not believe there's a productivity problem in the NHS? Of course I do. I know there's a productivity problem in the NHS. What I'm curious about is why we find it so difficult to solve it. And that's what led me to saying the teams that solve it, the organisations that solve it, have leadership teams that I sometimes think have to sort of create an umbrella around their organisation to allow them to have the space to work in different ways, to listen to each other in different ways, to be curious, to say, I'm very interested, if you look nationally, the makeup of the workforce, of the nursing workforce and the AHP workforce is now younger than it was in 2015, and more people have spent less time in the grade they're currently in. So they've been in that grade for less than a year. Now, actually, that should be something we celebrate. We've got a younger workforce and a workforce that is doing well in their roles. But all the international literature will tell you, we don't really have to read the literature to know that if you're younger and yes, experienced in a role, you're less likely to be as productive than somebody like yourself, Louisa, who's very experienced in their role, or Amar. So, it doesn't take a lot to work out. That's probably got impact, but we're sort of got a culture of such a lot of fear often in the NHS that just saying that can feel, I'm not trying hard enough. I should be doing something different. So we fixate on a few like capital and digital, which are absolutely true and are at the root of a lot of productivity problems, rather than allowing ourselves to look more broadly.
I wonder, Louisa and Thea, whether you might be able to help our listeners and watchers, many of whom are improvers or see themselves as improvers in the health and care world, or clinicians who are trying to make a difference and make things better. Wonder if you might be able to give them some advice and tips about how they could take this word productivity and translate it into a way that their team might find more meaningful, and that they can then bring to bear some of their skills, their clinical skills and knowledge, their improvement skills, to be able to make a difference, both through, making the most of the resources we have, but also focusing on the things that really matter to our local communities.
From my part, it was a really, really good question, Emma. So I think sometimes, in a transformation conversation, let's say, where you're wanting to do something that is not just sort of at the edges, tinkering at the edges, doing a small piece of work, but you actually fundamentally think that something needs to change in a big way. I think for me, what I feel is important is at first just to get that alignment and that agreement with the group that are doing that thing about what your ultimate destination is. Where are you traveling to, so that at least the vision that you have of where you're going to is shared. Now, the route to that vision, there may well be a lot of different views of how you get there, different disagreements, conversations. But it is important, I think, to have that shared vision of what you're aiming for. So, for example, when we've been doing the national work, what we're aiming for is to reduce irreversible, preventable sight loss, let's say. That's your vision. Now, at least if we have a destination, it's like a train, isn't it? We have a destination. Now, there are lots of different stops that we're going to need to make on that journey. And we might not all agree about where those stops are. We might not all agree what we're going to do when we get to those stops. But at least we have a shared vision of where we're going to. And that allows us permission to have those different conversations and also allow different people to try different things, because as Thea was saying earlier on, some of us will feel very strongly that we have the right answer, and we need to let those people explore that answer and if necessary fail in a supportive way, because you can't transform if you can't fail first. You can't learn to ride a bike if it's not all right to fall off it. You have to be able to provide a supportive environment that says to people, we want you to try, we want you to explore, within obviously safe parameters. We want you to explore, and if it doesn't quite work out, that's okay, because that still informs the overall journey and it tells us what was important and what's not. But without that shared buy-in of where you think the vision is, of where you're going, it's very different, because otherwise everyone's in a different train going somewhere different, and you're never going to get to that ultimate destination.
Super advice. Thanks, Louisa. Thea, what would you give as advice?
I sometimes think that we look for simple answers to productivity when we know it's complicated. And yet, because we're trying to work so quickly, we want there to be a reason that is quite simple. This theatre isn't as productive as that theatre, and it's to do with this. And so we'll do that. Occasionally there's a simple answer, but the NHS and NHS services are remarkably complicated and multifactorial. And actually understanding what is the productivity issue underlying orthopaedics in Bradford will be different from what is underlying cataract surgery in Moorfields, which is different from, community nursing in Leeds. And you have to take I think the generalizable approach is quite similar to doing root cause analysis. Keep asking why. Why? 7 layers of why will help you. We often get stuck on the first 2 layers. It's because of this, it's because of that. Well, it probably isn't. It's probably a whole range of issues. So for the improvers, I would say use all the tools that you've got. Personally, I'll ditch the language of productivity. It does nothing for me. It didn't do anything for me as a clinician. It didn't do anything for me when I was the chief exec. But I do know that there are people who do like it and do respond to it. So it's horses for courses. For me, it didn't work. And for me, it'd be going in there, having a real conversation based on, as Louisa said, a really clear outcome, even a higher order outcome. We don't have enough money to do everything we want to do for the population we want to serve. We've all made a decision to be part of public service. How do we make it as good as we can be? Nobody's there. Most people in the NHS could work somewhere else. They could work somewhere else. So they're there for a reason, and that's the higher order value to drive the conversation. That's what I do.
Fabulous. Thank you both. It certainly resonates with my own experience. All of our improvement efforts in East London Foundation Trust I don't think any of them have ever really had productivity as the aim. It's usually been a byproduct. But as you both say, focusing on something that really matters and everyone can coalesce behind, and then thinking, what can we do differently, having that permission to fail, thinking about the team and how we can work together to achieve it, testing ideas, really understanding the root causes, and taking a complex system approach to change has often led to improvements of which, being able to make best use of our resources is one of many benefits that we've been able to see. And I think there's lots here for those who are well practiced in the work of improvement science to be able to bring to help people start to get underneath this very simple word of productivity and understand the potential benefit, which is much wider, I think. I thank you both for helping us understand that a little bit deeper today. So many thanks, Thea, many thanks, Louisa, for joining us on this episode of Conversations in Health and Care Improvement. Thanks to our listeners for joining us today too, and look out for the next episode coming soon. Thanks, everyone. Thanks, Louisa. Thanks, Thea.